Bradyarrhythmias are heart rhythms with a rate of less than 50 beats per minute, commonly due to conduction abnormalities in the heart such as sinus node disease or atrioventricular block. The risk of sudden cardiac death is elevated due to the slowing or stopping of the heart. Additionally, there is an increased risk of falls, particularly among older adults, due to fainting. Patients may present with lethargy, shortness of breath, chest pain, dizziness, and fainting as a consequence of the reduction in cardiac output, and cardiac and cerebral hypoperfusion. Symptoms such as syncope are episodic and often infrequent. Approximately 20 to 40% of patients report an episode of syncope with bradycardia, and this may recur in 10 to 15% of patients. Bradyarrhythmias described in this chapter include sinus bradycardia, first-degree AV block, second-degree AV block, types 1 and 2, and third-degree, complete, AV block.
Sinus bradycardia is identical to normal sinus rhythm, except the rate is less than 50 beats per minute. Cardiac activation starts at the SA node but is slower than normal. Sinus bradycardia may be a normal finding in some patients, particularly healthy young adults and trained athletes. In other patients, however, sinus bradycardia is a pathologic finding.
Signs and symptoms. Sinus bradycardia may not cause signs or symptoms. However, when sinus bradycardia significantly affects cardiac output, signs and symptoms may include dizziness or lightheadedness, syncope, fatigue, shortness of breath, confusion or memory problems. On electrocardiogram, sinus bradycardia appears the same as sinus rhythm, except the heart rate is less than 50 beats per minute. AV block is a partial or complete interruption of impulse transmission from the atria to the ventricles. The block may occur at the AV node, the bundle of His, the bundle branches, or the Purkinje fibers. Common causes of AV block include fibrosis and scarring of the conduction system, and myocardial infarction. Other causes include medications, such as beta blockers, calcium channel blockers, datixin and amiodarone, electrolyte abnormalities, myocardial ischemia, infectious or inflammatory disorders, and congenital heart conditions. Depending on the cause, AV block can be transient or persistent. AV blocks are classified as first, second, or third degree. First-degree AV block is characterized by a prolonged delay in conduction at the AV node or bundle of His. The impulse is conducted normally from the sinus node through the atria, but upon reaching the AV node, it is delayed for longer than the usual 200 milliseconds, 0.2 seconds. In first-degree AV block, although the impulses are delayed, each atrial impulse is eventually conducted through the AV node to cause ventricular depolarization. Causes. First-degree AV block may be a normal finding in athletes and young patients with high vagal tone. It can also be an early sign of degenerative disease of the conduction system or a transient manifestation of myocarditis or drug toxicity. Signs and symptoms. First-degree AV block rarely produces symptoms. ECG findings. First-degree AV block is characterized by normal P waves that are each followed by QRS complexes. But because the impulse is delayed at the AV node or bundle of His, the PR interval is longer than normal. It exceeds 0.2 second. QRS complexes of normal duration suggest that the delay is occurring at the level of the AV node, whereas wide QRS complexes suggest that the delay is infranodal, distal to the node. In second-degree AV block type 1, also called Mobitz type 1 or Winkelbach's block, impulses are delayed and some are not conducted through to the ventricles. After 3 or 4 successive impulse delays, the next impulse is blocked. After the blocked impulse, the AV node resets, and the pattern repeats. Second-degree AV block type 1 usually occurs at the AV node, but may be infranodal. Because the block usually occurs above the bundle of His, conditions or medications that affect the AV node, such as myocarditis, electrolyte abnormalities, inferior wall myocardial infarction, or medications, such as digoxin, can cause second-degree AV block type 1. This type of arrhythmia can also be physiologic. Second-degree AV block type 1 rarely produces symptoms. Some patients may have signs and symptoms similar to sinus bradycardia. Because some impulses are not conducted through to the ventricles, the ratio of P waves to QRS complexes is greater than 1:1. Because each impulse is delayed a little more than the last until eventually one impulse is completely blocked, the ECG shows progressive lengthening of the PR interval with each beat, then a P wave that is not followed by a QRS complex, a dropped beat. In most cases, the RR interval decreases before each dropped beat. After the dropped beat, impulse conduction through the AV node resumes and the sequence repeats. In second-degree AV block type 2, Mobitz type 2, the block occurs below the AV node, in the bundle of His. As with second-degree AV block type 1, some atrial impulses are conducted through to the ventricles, and others are not. However, there are no progressive delays. The blocked impulses may be chaotic or occur in a pattern, for example, 2:1, 3:1, or 4:1. In high-grade second-degree AV block type 2, the ratio is greater than 2:1, for example, 3:1, 4:1, or variable. Second-degree AV block type 2 is always pathologic. It is usually caused by fibrotic disease of the conduction system or anterior wall myocardial infarction. Signs and symptoms. Patients may present with lightheadedness or syncope, or they may be asymptomatic. The clinical presentation varies, depending on the ratio of conducted to blocked impulses. ECG findings. Second-degree AV block type 2 is characterized by a constant PR interval. Because impulses are intermittently blocked, there are more P waves than QRS complexes. In third-degree, complete AV block, no impulses are conducted to the ventricles. The block can occur at the level of the AV node, but is usually infranodal. Pacemaker cells in the AV junction, bundle of His, or the ventricles stimulate the ventricles to contract, usually at a rate of 30 to 45 beats per minute. This means that the atria and ventricles are being driven by independent pacemakers and are contracting at their own intrinsic rates, a situation known as atrioventricular dissociation. Causes. Degenerative disease of the conduction system is the leading cause of third-degree AV block. This arrhythmia may also result from damage caused by myocardial infarction, Lyme disease, or antiarrhythmic medications. Signs and symptoms. If ventricular contraction is stimulated by pacemaker cells above the bifurcation of the bundle of His, the ventricular rate is relatively fast, 40 to 60 beats per minute, and reliable, and symptoms may be mild, such as fatigue, orthostatic hypotension, and effort intolerance. However, if ventricular contraction is stimulated by pacemaker cells in the ventricles, the ventricular rate will be slower, 20 to 40 beats per minute, and less reliable, and symptoms of decreased cardiac output may be more severe. ECG findings. In third-degree AV block, there is no electrical communication between the atria and ventricles, so there is no relationship between P waves and QRS complexes. The RR interval is usually constant. The PP interval is constant or slightly irregular. If pacemaker cells in the AV junction stimulate ventricular contraction, the QRS complexes will be narrow, less than 0.12 second in duration. Impulses that originate in the ventricles produce wide QRS complexes. The patient's appearance on rapid assessment can vary widely, depending on the arrhythmia. The patient may appear to be in minimal distress, show signs of hemodynamic compromise, for example, pale, mottled, or cyanotic skin, or show signs related to the underlying cause of the arrhythmia. For example, pain, diaphoresis. Primary assessment. Conduct a primary assessment following the ABCDE approach and provide care as needed. Obtain and monitor the patient's vital signs. Establish cardiac monitoring, pulse oximetry, and vascular access, and be prepared to provide CPR and defibrillation if the patient's condition deteriorates. Provide the minimal level of supplemental oxygen needed to maintain an oxygen saturation of at least 94% to 99%, and provide assistance with ventilation if needed. Assess level of consciousness in patients who appear to have changes in mental status. Obtain a 12-lead ECG if time and resources permit. Secondary assessment. The goals of the secondary assessment are to identify signs and symptoms and determine whether they are being caused by the arrhythmia or another condition. Further, determine the severity of the signs and symptoms. Identify the arrhythmia, if not done as part of the primary assessment. Identify potentially reversible causes of the arrhythmia. Key information to elicit during the history includes a description of the patient's symptoms, including a full description of symptoms such as chest pain or syncope, a medical history of arrhythmias, cardiac disorders, or cardiac surgery, the presence of comorbid conditions, including cardiovascular disease, pulmonary disease, and thyroid disease, current medications, including antiarrhythmic agents, physical examination, obtain and monitor the patient's vital signs, and perform a physical examination, diagnostic tests. A 12-lead ECG aids in further identifying the arrhythmia. Additionally, a complete blood count, comprehensive metabolic panel, arterial blood gases, and cardiac markers may be considered. When bradyarrhythmia is suspected, the team takes actions to ensure adequate airway, breathing, and circulation, including obtaining and monitoring vital signs, establishing cardiac monitoring and pulse oximetry, administering supplemental oxygen if needed, and ensuring vascular access. If time and resources permit, a 12-lead ECG should be obtained because care depends on whether the patient has adequate perfusion or is hemodynamically compromised. Assessing indicators of perfusion status, such as mental status, blood pressure, and pulses, is key. Findings that may suggest that the patient is experiencing hemodynamic compromise include changes in mental status, ischemic chest discomfort, hypotension, signs of shock, or acute heart failure. If the patient is not showing signs and symptoms of hemodynamic compromise, the patient's condition should be monitored. Cardiac monitoring, non-invasive blood pressure monitoring, and vital signs. A 12-lead ECG may be obtained, and an effort should be made to identify and address the underlying cause of the bradyarrhythmia. Consider expert consultation. If the patient has signs of hemodynamic compromise, initiate treatment immediately. It may be necessary to implement multiple treatment measures simultaneously. First-line therapy is with atropine. Second-line therapies include transcutaneous pacing and beta-adrenergic agonists. Consider expert consult and transvenous pacing if first and second-line therapies are not effective. Atropine is an anticholinergic drug that increases SA node firing by counteracting vagus nerve action to increase the heart rate. It is the first-line therapy for bradyarrhythmia with hemodynamic compromise. Administer a 1 mg bolus intravenously every 3 to 5 minutes, up to a maximum dose of 3 mg. If the atropine is having no effect, do not wait to reach the maximum dose of atropine before initiating second-line therapies. If at any point atropine is not effective, consider initiating transcutaneous pacing as a second-line therapy. Consider implementing transcutaneous pacing immediately if vascular access is difficult to achieve. Transcutaneous pacing can be painful. If the patient's clinical condition permits, administer sedation or analgesia before pacing. After initiating pacing, verify electrical capture, evidenced by wide QRS complexes and tall, broad T waves following each pacing spike on the monitor. Confirm mechanical capture by assessing the patient for clinical signs of improved cardiac output. Epinephrine or dopamine may be administered to patients with symptomatic bradycardia as an alternative second-line therapy. These medications may also be considered when the cause of the bradyarrhythmia is an overdose with a beta blocker or calcium channel blocker. The initial dose is 2 to 10 microgram per minute by intravenous infusion for epinephrine or 5 to 20 microgram per kg per minute by intravenous infusion for dopamine, and then the dose is titrated to the patient's response.